So it is, oh, it's July 1st. Ooh, July 1st, and it's our final kind of study session for the July boards. And does anybody know what famous battle started today on July 1st? Because this is a good one, because you know me, I've got to give history a little bit. Today was the first day of the Battle of Gettysburg. Yep. It was also the Battle of Malvern Hill in Virginia too during the Civil War, but the Battle of Gettysburg is a little bit more well known, at least. But yeah, today was first day of Battle of Gettysburg, which is kind of cool. Well, not really kind of cool. That sounds bad. It's kind of cool for history, at least. And hopefully we never go there again, is all I've got to say. But I kind of went through some neuroanatomy, and along with, I got some questions on pediatric reflexes and brain lobes. And there's one other one I think that I got down here that I can't remember. Oh, open pack, closed pack that I got some requests for. So for brain lobes, traditionally, the brain lobes are divided into those 4 lobes: the frontal, parietal, temporal, and occipital. And if you remember basically what those do, when you get questions on things such as traumatic brain injuries or strokes, it helps you answer the conditions they experience, right? So we got our frontal lobe up here. That's our higher executive function, emotion regulation, planning, reasoning, problem solving. And this PowerPoint will be available for you, right? So that's here. We got our parietal lobes kind of out here that help with sensory information, touch, temperature, pain, and pain sense. There's also some motor function there, right? Then there's temporal lobes. Temporal is primarily listening and hearing, along with some visual and memory impairment. And then occipital, the main thing that you've got back there is obviously vision, right? So 9 times out of 10, if you get a question about the occipital lobe, it's going to be dealing with vision. And then, of course, Jason's going to tell me he got that one question that was something else on the occipital lobe, but oh well, not just kidding. But primarily it's vision. So I like this picture here that kind of shows the lobes themselves. So we got our frontal, we got our temporal, parietal, occipital. And then if you look at the general homunculus, this is kind of what it looks like. So our frontal lobe's got that planning and attention. Our movement kind of sits like this in almost what's now being known as the coronal lobe, because it's where a crown would sit on your head, or a tiara if you want to go there, right? Our movement kind of moves through here. So it's kind of split a little bit between that parietal and frontal lobe. Touch kind of sits here, taste here. Our hearing sits right above our ears, which is important. Same thing with our memory processing. That's why there's a lot to do with listening and memory recording. Our speech sits kind of like just up on the front tip of our ears. Vision's back here, and the motion movement coordination sits at the base, which is what we'd want. And then the heart rate and breathing is definitely the bottom of that brain. But for the most part, if you get a question that would say that your patient has a stroke in your frontal lobe, what would you expect of them? That patient's going to be poor in decision planning. They're not going to have a good attention span. They're going to take risky behaviors. So that's kind of what happens when we have those frontal lobe injuries, right? The parietal present as TBI, right? Yeah, exactly. They're going to be, and especially if the TBI there is combined with it, right? And then usually, again, for the most part, when you talk about that parietal, they're talking about a lot of our senses. So the senses are the most affected, or movement in general. And then obviously over that temporal lobe, or the temporal lobe, and over the ears, most of that's going to be our hearing. That's almost 9 times out of 10, the question is going to be about hearing, except for that one time that it might be about like memory processing. The back, obviously vision. And then when you get to that brainstem, the brainstem is, what's the main job of the brainstem? Yeah, ANS, right? Managing everything that we don't have to think about. Because you and I all have that friend that if he had to think about breathing, he'd die. Right? Or maybe it might be us. I'm not sure. Maybe me at this point. So that handles everything that's just that base level function: breathing, heart rate, respirate. Excuse me. Just our general function in general down there kind of moves. And then we got obviously the cerebellum back that handles movement coordination. let's just kind of think this through really quick. If I have an apraxic problem with movement coordination, what does that mean again?
Problem with implementing the motor plan.
Good, right? And then ataxic is implementing, is the actual movement itself, doing it, right? It's taxing to do it. Good. I just want to make sure that you got that because I had a couple that were asking about the aprax versus atax issues. Do go back and go over ideational versus idea motor. Do you remember that briefly that we talked about that? Make sure you kind of hit that. Yeah, you're not likely to get 10 questions on it, but that one question you get on it is going to be useful. Just remember that one of those they can't perform it, and the other one they can perform it, but not at a command, right? All right. Since Dr. Crane really loves the Asia assessment, like really, really loves it, to the point of like 9 questions on it. The only thing I'll say that's kind of useful in the Asia assessment for me is the myotomes or dermatomes, I mean. And it also is useful when obviously I'm working with the patient of it. But the nice thing about the Asia assessment is it has your dermatomes and myotomes kind of on one sheet for you. Remember your dermatome, whether you did a dance or kind of a So when you're doing those things, when you get a question on dermatomes on your boards, I was going to say touch yourself, but that sounds really weird. Right. But go through your process of, okay, C2, C3, C4, 5. Yeah, I missed the free throw thing. Unfortunately, I had a phone call that I heard it when I came back, but I didn't get all of it. So is it the one where he's talking about the way to go through it? Is that what he's talking about, Anthony? Yeah, I've seen that before. I don't get it because I don't understand free throws probably. I'm just going to be honest. So there's that. You could probably teach me that, Anthony. I'd still have no idea because I miss 99% of the free throws I don't take. So I just kind of remember by going down through, and it's the old habit of going down through and going, oh, it's down T1, T2, 3, 4, right? T4 is always the one everyone remembers. And it's usually a good question they get because for some reason the nipples are hard to forget. And I once had a student, actually, I think it was the new group that just asked me, well, is it still T4 if they're down towards their knees? Yeah, it's still T4. It's just T4 is now stretched. I just chuckled. I was like, yeah, it's still T4, right? Maybe it's T14 because 4 plus 10 could be overlapping each other. I don't know. And then T10 is the belly button. So I remembered when I was doing this for the body, I remembered key points. So I remember T4 was here, T10 was here. And then if there's a question about like 5 or 6, I knew it had to be between them. And that was my way of remembering, because remembering every dermatome is a pain in the butt. And then just go back down to the L1 of L1, L2, L3, L4, L5, L6. Yeah, retired Pete asked for T10. Of course it did, right? You tickled your belly button. Don't tickle patients' belly buttons. That's just mean. Especially if there's spinal cord injury, you can't feel the tickle. And then, of course, the easy ones that everyone always remembers along with those is S3, S4, S5. Because if you don't have those, remember, it's just always going to be a crappy situation. Because you can't feel that coming. Those are the dermatomes that affect us when we're not sure if it's a poop or a fart. So just saying. And then they tell us afterwards. Because you can feel it. Get it? I'm funny. I'm funny. I'm so funny. This is going to get age restricted. And then with like myotomes, the Asia is good, but I kind of like this myotome chart gooder for it, right? Tells you where each of them are. So C2 is neck flexion extension, C3 is lateral neck flexion side bending, shoulder elevation, abduct. Oh, I can see that. I see the free throw thing now. Okay. Now it hit me after it just took a little bit. It just took a little bit. Does finger abduction go in with that? I don't know. That's weird. And with the, with my martial arts background, the leg kind of reminds me of that as well, because I'm hip flexing, knee extending, ankle dorsiflexion. So I'm hitting with the heel with a kick. So that one always reminded me when I was practicing that one. That
Mr.
everything kind of goes,
McKeever,
if you look at that, it'll go in line with what's happening.
I have
Um,
I have a quick question about the Asia chart.
Yep.
So I've had some questions where I've followed the graphic that you were just showing us, and I got some answers wrong for spinal cord injury stuff. Are they
Okay.
the same or are they different?
For spinal cord injuries, it should be the Asia assessment.
So they
Um,
should be the same. So then I just made a mistake.
I don't know. Maybe if you can bring the question, maybe I can go over it with you.
Okay,
Um,
I'll try and find it later.
Okay. Yeah, I mean, even if you text me it later, I can probably look at it for you too. If it's not something you have really available, but it should be the same. Most spinal cord injuries should follow Asia. If not, it may be that weird overlapping dermatome. Like there's a small part of C8 and T1 that overlaps, and those are really the annoying ones. But again, myotomes. This was my brain dump. I'll be honest. When I sat down, I did a quick dermatome and a quick myotome, and then a cranial nerve. That was my part of my brain dump when I sat down, and I put those down on my sheets so that it at least gave me. And I didn't have all of them down, but I had a good chunk of them down so that if I had a question that wasn't related to them, I could at least answer that question. As far as the individual nerves, it's unlikely that you'll get asked, to explain the lateral cutaneous nerve or something like that. But your big nerves, your musculocutaneous, radial, ulnar, fibular, peroneal, those nerves, the peroneal and fibular are the same thing. That was a good job, Mr. McKeever. What other ones might be? Sciatic, median. There we go. Yeah. So those nerves are likely to have questions on them, specifically the hand nerves, right? Your median, ulnar, radial, just because they like to ask you questions about what happens at the hand when those get damaged. So don't get lost in looking, because I had one of your fellow classmates text me. It's like, I don't remember us talking about the medial and lateral antebrachial nerves. And I guess there was some question somewhere that they ran into, and I'm like, yeah, the likelihood of that happening is really, really low, right? But if you think about it, medial versus lateral antebrachial, right? Antebrachium, medial, lateral, and just kind of think through logically. And the best part about it is the question it gave me had nothing to do with those nerves anyway. They were just talking about it in the question to throw you off. Oh, spinal cord. How many of you guys remember all of this? This is really dark. I wonder if I can change that. The main thing with the spinal cord tracks, and I hope that you've kind of seen it, is just kind of determining if they're ascending or descending, first of all. And then if I get damage to a certain part of the spinal cord, what does it look like? If I get damage to the posterior aspect of the spinal cord, I'm losing a lot of my afferent pathways because I'm losing my dorsal columns. And my dorsal columns are kind of the big system of those sensory nerves heading up. And then if I'm kind of posterior and medial, I lose a little bit of my motor tract along with some of my spinal cerebellar tracts. And then when I get all the way in the front, in the most protected area, that's where a lot of my motor tracts exist, because we'd want to protect them as much as possible so we can function, right? Remember again that the tracts are named from where they start to where they end. So if you get a question on whether it's afferent or efferent, if it says spinothalamic, starts at the spine and goes to the thalamus. If it says vestibulospinal, it starts in the vestibular system, goes down to the spinal region. So it'd be ascending versus descending that way. They're not going to try to trick you on the vestibulospinal, because vestibulospinal can be both vestibulospinal and spinal-vestibular, because it's an afferent tract. It does send some signals both ways. So don't expect them to trick you on that one. I would not say at this point, this is time to go look at this and study and freak out about it, but just kind of make sure that you understand generally where your tracks are and what they do. Spinal cord injuries, just to kind of review those as we go down through it, because we just brought that up. The difference between a complete and an incomplete, they are not going to be calling them A or B class spinal cord injuries. Just to let you guys know, please don't think that. That's Asia assessment. They're going to call them complete or incomplete. That was what it was last night that kind of went off on a little bit. That your test will say your patient has an Asia level C8 complete. So that'll tell you that they've got no S4, S5 function, right? Incomplete, they have S4, S5. Which has a better chance of recovery, complete or incomplete?
Incomplete.
Incomplete, good. Yep, good. Incomplete has a better chance of recovery. So just remember that incomplete means that they've got some bowel and bladder function, right? And some function below the level of injury. And we have those zones of partial preservation in those weird people. Those are the people that have that full complete spinal cord injury. So a question like this would say that you have a C7 complete injury and your patient has great toe extension. What is causing this? That would be a zone of partial preservation. We have no idea why this happens, but sometimes weirdly it just happens. So that zone of partial preservation follows those complete spinal cord injuries when they have something weird below that. Now that won't give them a S4, S5, but it's going to give them some weird preservation somewhere else. And then obviously sacral sparing is what we call a patient that's incomplete because they have a lesion in those centrally spared sacral tracts. When I came to studying the clinical syndromes, what I focused on was what my losses were. So Brown-Séquard, which is most of your questions, Brown-Séquard is stabbing, shooting, lateral injury. And they're going to lose on the same side, motor function, proprioception, and vibration sense. On the other side, pain and temperature. I didn't focus on what they had because 9 times out of 10, the questions weren't asking me, what does your patient possess? They were asking, what does your patient lose? So I focused on what I lost. Anterior cord syndrome is a flexion injury against anterior cord that's getting compressed. So I'm going to lose pain, temperature, and motor. And obviously, if the anterior portion is injured, the posterior portion is going to be preserved. So a lot of my dorsal columns are saved. Central cord syndrome, kind of in the middle portion, the most common incomplete injury. You usually have more upper versus lower injuries. And then you have that mixed bag symptom where we have upper motor neuron versus lower motor neuron symptoms. And they end up with hyperpathia. Why? What motor tract would cause them to have hyperpathia? Where they might get thalamic pain syndrome.
Spinothalamic?
Yeah, exactly. Yeah, right. So don't let that trick you. Don't let it overthink you, right? They'll say, well, the patient has hyperpathia. When you have hyperpathia or allodynia or any of those weird pain signs, most times it's the spinothalamic or the thalamus that's the problem. Right. So like that's one of the things that kind of stuck in my head is I'm like, okay, anything weird dealing with pain is almost always the thalamus or the spinothalamic tract. Posterior cord is severe hyperextension condition is rare because we have that ALL that protects us. So that's one of the questions I had from somebody that asked me like, well, I got a question on this, but it asked me what protects us from having a posterior cord injury. And it's the ALL that protects us, the anterior longitudinal ligament, because it's thick and broad and it keeps us from really hyperextending. The other thing is we have the good old spinous processes back there that keep us from hyperextending too much as well. With posterior cord, you're going to lose almost all of their dorsal columns. So lose proprioception sense and a lot of their general touch senses, like deep touch, baroreception, and stuff like that. But they'll keep motor function because those motor functions are usually anterior located. They may keep some light touch, some temperature, and the spinothalamics in track, so they're not going to be in as much pain. Root escape is, again, anytime you think of root escape or root escape, I got to get out of my Pennsylvania, root escape. Thanks for, I saw Riley smiling there when I was saying it. Root escape injury. I want you to think of me because I have a root escape injury, right? My injury was to my spinal cord, but it was more to the root that escapes the spinal cord. And that means that it's going to be a PNS nerve injury. They have a higher rate of return, a higher rate of function, but at how long with both Caudarcliner and root escape is it till those symptoms are 100% permanent, or actually any spinal cord injury? How many months? What do we say?
3.
Well, yeah, definitely Caudarcliner. Okay, let's throw Caudarcliner out. Root escape and spinal cord, remember, anything they have at a year is probably what they're going to have. Yeah, 12 months. Yeah, same thing with strokes, actually, believe it or not. In the general rule of things, anything past 12 months, we're probably not going to regain it. Does that make sense? Because, you know, when I lost at 12 months, when I didn't have any sensory feeling in this arm, I knew that was permanent. But again, my main thing, I'll be 100% honest. Yeah, I was worried about the sensory loss when I was that. My main thing is I didn't want to lose motor function. Right? I wanted to make sure I kept this because if I lost motor function to this hand, I'm not working as PTA anymore. I can live with sticking my hand in a hot pack and forgetting, or hydrocollator and forgetting that I burnt myself. That's functional. Just tell myself, don't pick stuff up with this hand. Right? So anything out 1 year is the main goal. Caudarcliner. What is the symptoms of Caudarcliner? I have it down there, but try to go without answering it down there.
Saddle paresthesia.
That's the big one. Yeah. Right. So they'll say your patient has lost the sensation on the inside of their legs. Right. It is the horse's tail that's damaged. Yes. So they'll say they have saddle anesthesia. It's bilateral. So remember that. So both legs, they have numbness and tingling. They'll often have leg pain and then bowel bladder or sexual dysfunction. That's a compression of that Caudarcliner. Yes, and it is an EMS situation. They need to get surgery right away, or it could become permanent within 48 hours. Definitely at 3 months with Caudarcliner, it's done. It's just the way it is. That's the basics on spinal. I broke that down to like 2 slides for spinal cord. I know. I've had a couple of you ask about this. You're like, Mr. McKeever, I am getting lost on upper motor neuron versus lower motor neuron. I hate this. This is probably the, and I'll admit, most of the time, this is the one that causes the most, the most problems, right? This chart came out of one of the recent neuro books that I found, and I like it, but I like my breakdown a little bit better. But the main thing is when you're looking at upper motor neuron versus lower motor neuron, I usually think upper motor neuron is brain and spinal cord. Lower motor neuron is anything out past the anterior horn cell. Right? So that would be PNS related, right? So they say, yeah, upper motor is pyramidal and extrapyramidal, and lower motor neuron is the muscle nerves themselves. So that means upper motor neuron is more likely to occur in spinal cord injuries and brain injuries, right? Versus lower motor neurons could happen in entrapments or anything like that as well. What is the one condition, the one medical diagnosis that is terminal that shows as a mixed bag of upper motor neuron and lower motor neuron injuries? The only reason I'm asking this, there's a question on this. There's one specific condition, ALS. Yeah, right? ALS is that mixed, what they call the mixed bag. And usually what you have with that, with ALS, it's really weird. It's usually their lower extremities have lower motor neuron and their upper have upper motor neuron, or the vice versa. And it just kind of gets really screwy. So if you get a question, and I guarantee it'll probably be worded that way. If you get a question that's talking about this condition is a mixed bag of upper motor neuron, lower motor neuron injuries, it's probably going to be ALS. Again, general rule of thumb, make sure you read the question so that, you know, Jason doesn't get mad at me. But general rule of thumb is that would be an ALS symptom. So I have this on here because this came out of this. My breakdown, I think, works a little bit better. And my breakdown is upper motor neurons above or below the anterior horn, above or before the anterior horn cell, CNS, right? So they're going to be hyperreflexive, have disuse atrophy. They may have some fibrillation. They'll be hypertonic and loss of manual control, or not manual, automatic control. So the way I think about this is I'm hyperreflexive. So if I'm hyperreflexive, I could get quivering. And if I can get quivering, that means I'm hypertonic or spastic. If I'm spastic, I can't control it. That gives us that upper motor neuron symptoms. If I'm hyperreflexive, it also means that I could get clonus or a positive Babinski. And they'll often get spastic paralysis where they're stuck and they can't move because the muscles are just locked up. And with spasticity and hypertonicity, remember, most times it is velocity dependent, meaning if you pull slowly, you're easier to get them out of that spasticity versus just yanking rapidly. If you yank rapidly, you make that hypertonicity or spasticity worse. What type of spasticity is really the only type that isn't velocity dependent? Do you guys know? It'd be the type that you can't put any velocity on anyway. Lead pipe. Right? Because if they've got lead pipe, are you really going to be able to move it anyway? No, it's going to be like this. You're like, So velocity doesn't matter at that point. They're locked up. Lead pipe responds really well to cold. Right? So cooling, actually all of the spasticity responds really well to cold, but lead pipe's one of those that I use cold a lot for, or EMS in the opposite and trying to get reciprocal inhibition going. So upper motor neuron, super reflexive, which means I've got some spasticity going on, which means I can't control it. And why would they get disuse atrophy? Well, that always confused me. Why would they get disuse atrophy? Because you're like, well, it's contracting.
But they're not actively working the muscle.
There you go. That's it. That's what, and it's, but it is confusing, right? You think the certain thing, well, it's spastic, so they shouldn't waste away. But they're not also lengthening as well. And in order to keep the atrophy from happening, they have to lengthen and shorten, lengthen and shorten, lengthen and shorten, right? So yeah, I know it seems silly. Like that was one of the things I just, for whatever reason, when I was in neuro class, I'm like, that makes no sense. And it took me a couple years to like kind of hit my head. And when it did, I was like, oh, that makes sense. Now I'm an idiot. Lower motor neuron, again, after or below the level of the anterior horn cell, that's usually the way they define it. Oftentimes I just say it's PNS. At that point, because that anterior horn cell is now disconnected, they don't get reflexes at all because you can't do that 2-point reflex arc. Remember that from back in anatomy? Where he hit it, it goes back. Well, it's going to go to that anterior horn cell and die there. It can't go anywhere. So that means they're going to have hyporeflexia, almost no reflexes. If I'm hyporeflexive, my arm's probably going to be flaccid. It's going to be noodly, right? They could have some fasciculations, but not usually. And the main idea here is neurogenic atrophy. So versus the other side where the spasticity is wasting it, but it's not, it's because you're not lengthening and shortening. In this case, because you're not using it all, it wastes right away. And neurogenic muscle atrophy is the worst. That's what I kind of experienced briefly when I injured my spine. Is that the muscles in my arm just still to this day, they're still not fully, I mean, you can see that I've still got some, you can see most of the muscles in my forearm. If you compare it to this forearm's definitely beefier. I'm not trying to show off my guns here. I'm just saying. I don't know why I show off guns down here. These aren't guns, but then can I get the weird anomalous muscle to show up today? You see the weird anomalous muscle in my wrist? Isn't that great? Oh, weird muscle. I have like a secondary extensor or flexor of my fingers. It's really weird. Anyway, side note. So lower motor neuron injuries below, upper motor neuron injuries above the anterior horn cell. Upper motor neuron injuries, hyperreflexive, lower motor neuron hyporeflexive. If you can remember those, that should get you through it. So a question for ALS may look like your patient has clonus of the foot along with hyperreflexia of the patellar tendon reflex. this would be presenting as what type of a motor neuron injury? Hyperreflexive clonus upper. Does that make sense? That would be how they tie it into ALS, or they'll say it's a mixed bag, and then you run on to ALS. I got that. Mr. McKeever said that. I don't think the person that sent this is actually in the chat right now, so we'll skip on. Pediatric reflexes. This one was one that I got like 5 emails on, because they're like, oh my God, I went back and looked at pediatric reflexes and there's so many, what the hell? Yeah, Jason's like nodding his head, right? When I studied these, I had to remember that pediatrics only makes up a small portion of our population. So there's not going to be 3,000 questions on pediatric reflexes. If there's going to be questions on pediatric reflexes, it's going to be questions on the ones that the people that write the test questions can actually remember. So there's the good news. They're not going to write questions on ones they don't even remember. And, you know, a book will say that it integrates at X, Y, while test prep says that it, you know, integrates at Y, Z. So how do you know what's right? The best way I can give you this is generalize it, right? So looking at the gallant. Gallant is touching the skin on the spine from the shoulder, and you should see lateral flexion to the side of the stimulus, right? That's that kind of rotational stimulus. Should integrate to within 20 weeks to 2 months after birth. So I would look at that and go, nope, range is too much, right? So what I see there, 20 weeks of gestation, 2 months, I say that it has to be integrated by 2 months, right? And 2 months is close to 3 months. So I grouped into quarters. I said, gallant must be integrated by 3 months. Anything after that is going to be outside the range. Anything under that will be inside the range. And that helped me kind of organize it, because what you need to know is it normal or abnormal to have that integrated or not integrated. And that's where reading the question is going to be coming into. And something like gallant, the turning the spine, is going to be integral to getting balance, and also could lead directly to scoliosis for the baby, which would be bad because we know that the spine is still in development in the baby. And if they get scoliosis, then it could become structural instead of functional. And once we have structural scoliosis, it's problematic. So I prefer this chart here. This is kind of one of my favorite charts when it comes to this. And mainly because I can print this, and when I'm in the clinic, I can carry this one with me. I forget who developed this chart. I think it's just one of the charts from the like clipboards or something like that. I can't remember. But looking at this, just remember going down through. So we have our primitive reflexes, we have our tonic reflexes, and we have our midbrain reflexes. And you're like, I don't remember any of that. That's okay. What ones would I remember? Plantar grasp, palmar grasp. Both those are important for development. That's fine. Got it. And trust me, I know. So plantar, palmar grasp, and Moro. Out of my primitive spinal reflexes, those are the most important. So looking at plantar grasp reflexes, right? What is plantar grasp dealing with? It's with the foot, right? Because plantar. So plantar grasp maintain flexion of the toes. So it has to integrate so the foot goes kind of flat. If you look at it, it has to be integrated by 9 months. Why would you want that integrated by 9 months? Does anyone have an idea?
So they can start walking.
Yeah. So integrate before they start walking. Great. Exactly. Both of you. So I go, okay, well, if it has to integrate by 9 months, that also tells me that what starts around 9 months? Walking. Yeah. Right. So I can use both those to remember a subject. So a question on that might say, your patient, your pediatric patient still does not demonstrate integration of the plantar grasp reflex. Which of the following ranges is outside of that range? So it'll say like 1 month, 3 months, 6 months, 24 months. 24 months is definitely outside of the range for integration, right? And so you're, oh, that's the one that they're kind of telling me that is outside of the range. Palmar grasp is for this, right? Why would they want that? Well, that's so that they can actually help get everything up and get them moving. If you look, it's a little earlier. 4 to 6 months. So I always remember that it's about 6 months that Palmer has to be. And it helps pull up stuff like that. And then Moro. What's the Moro reflex? You remember what that one, the other name for that one is?
Startle reflex.
Startle reflex. Yeah, the crying one. Exactly. Right? Because you're basically scaring the baby. So when you drop their head in supine, they do this. Right? They extend back to keep the head from flopping around. Well, in order for Moro to integrate, I have to have head control. Right? That makes sense. And head control takes a little while to develop, but it has to be usually developed by about 6 months. Well, look, the Moro has to be integrated by about 6 months. So for my primal, those are the ones I remember for that. For the brainstem or the tonic-clonic ones, ATNR, STNR, and then TLR, tonic labyrinth reflex, are the 3 main that are there. The supporting and writing reaction ones, yeah, they're important, but I'm going to be honest, you're not likely to get questions on the writing reflexes. And there's a reason for that. There's a lot of argument with the writing reflexes. And a lot of the books argue, does it integrate by this time? Does it integrate by that time? And not only that, but if you look at like, when you get down to those midbrain, they could integrate up to 5 years. That's a lot of time. Right? So you tend to stick to the ones that integrate in a couple of months. So the one thing I remember is, so between ATNR, STNR, alphabetically, ATNR comes before STNR. So that means ATNR integrates first and then STNR integrates. So ATNR is by 6 months. And then I go, okay, well, what's double that? 12. So I remember that ATNR is 6 months, ATNR or STNR is 12 months that they have to integrate by. Right? ATNR is this one, right? Otherwise known as the fencer reflex. And then STNR has to do with the actual flexion and extension of the head, right? They kind of keep everything tonic with it. Tonic labyrinthian is developing our, oh my God, my brain just completely wiped there. Hold on a second, let me rewind. Developing our patterns for brain injury, honestly, because it helps us develop whether they're decorticate or decerebrate posturing develops, if you look at it. So tonic labyrinthian talks about either a flexion pattern or an extension pattern based on the position they're in. And that eventually will lead to us developing those the decorticate or decerebral posturing when we get injuries. The good news is both tonic labyrinthian and supporting reaction are both 6 months. So I'm like, great. So most of the tonic ones have to be integrated fairly early, with the exception of STNR, which can be integrated about 12 months. So 6 for all of those, and then 12 for the STNR. A good rule of thumb, and it's not perfect, but a good rule of thumb about pediatric reflexes, most of them have to be integrated by the 6-month mark. Not all of them, right? STNR obviously is kind of a weird one out, and also same thing with plantar grasp. But for the most part, they have to be integrated by the 6-month period, right? And that kind of helps me keep it that way. The other reason I really like this chart is because of the developmental portion at the bottom. The baby development. You're not likely to get this. Again, somebody sent me a question on this as well. You're not likely to get a concerned question on the baby is at 17 months and what are they likely to do? Is it throw forward, ball forward, walk upstairs? No. But your general development from rolling, right, at about 3 to 4 months, sitting without support at about 6 to 8 months, and then creeping about 9 months, right? And that's why we have to have that reflex integrated. All of that is kind of there, but they're not likely to ask you at what point does a child able to put cubes into a container. That's not going to be one of them. If you work in pediatrics, you do have to know that, right? But it's not likely to be one of the questions you're going to get on your boards. It's more rolling, sitting, standing are your questions you'll get on development. So don't totally freak out about those. Lung capacities. I know this is the one I actually did get a couple of you say that you wanted me to kind of go over, right? And I will be honest, I actually talked to the respiratory therapist program director, and she's like, I hate that chart. So it's not only us. So they hate it as well. It's like, it's not completely accurate. I'm like, whatever. And, so respiratory therapy just hates this. For your boards, obviously I have the chart coming up here, right? Understand what the words mean. So anatomical dead space is when you get air in non-breathing areas. So air in areas that there shouldn't be air. Expiratory reserve volume. Expiratory, breathing out. Reserve, extra amount, right? So expiratory reserve volume, when I'm breathing here, I'm going at my normal tidal volume. Expiratory reserve volume, if I take a normal breathe in and a normal breathe out, expiratory would be, say, the amount that I can breathe afterwards. I always think that expiratory reserve volume is really useful in heavy metal, because when they're giving a really good scream, like a Wilhelm scream or whatever on stage, I need to have that as much air in those lungs as possible to exhale it. So it's that amount that I can breathe after a normal breath. So breathe in, breathe out, and then keep breathing out and keep breathing out, keep breathing out, keep breathing out until I can't talk anymore. That's my expiratory reserve volume. That goes with forced expiratory capacity. That's the maximum amount of air that I can actually exhale. So if I just keep breathing until I turn blue in the face, that's going to lead to my forced expiratory capacity. Forced vital capacity is the amount of air that can be moved in the lungs. It is not normal breathing. So that would be a patient that's trying to do it. This is your typical kid that's trying to hyperventilate. Residual capacity is the amount of air laying in the lungs after a normal exhalation. So this is just when you have your normal tidal volume, it's how much is just sitting there in addition to that. The only condition that really worries about that is COPD, right? So that residual capacity, the FRC, is important for COPD. Inspiratory capacity, the amount I can breathe in, right? The maximum amount. If expiratory reserve volume is the maximum amount I can exhale after a normal breath, inspiratory reserve volume is the amount I can inhale after a normal breath. So if I just take a normal tidal breath, there's my normal tidal breath, but I can also then suck in some more, right? So that would be, for those folks that partake in the sticky green leaf, that would be fully inhaling that sticky green leaf, right? I'm just saying, or so I understand. I don't know. Minute volume ventilation is just comparing how much air is moved in a minute. Peak expiratory flow is the flow of forced air during exhalation. Residual volume is the amount stuck in after a maximal expiration, problematic for CV or COPD. Tidal volume is the normal breathing. That's normal quiet breathing going in and out. Total lung capacity is the amount of air that's available in the lungs, and that's usually measured in liters. And then vital capacity is the maximum inspiration followed by maximum expiration. So that's when what is my vital capacity? Excuse me. And that has to do when they're working on that nice inspirometer, right? So looking at this, there's a lot to go over here, right? Your tidal volume is kind of that stuff that's stuck in the middle. On either side of the tidal volume, we have our ERV and our IRV, the amount that we could breathe in on top of that. And then you look at what's left over, right? So when I look at this, I go, well, IC is IRV plus TV. FRC is ERV plus RV. And I just do my simple math problems. If this really made sense to me for some reason when I was going through school, I don't know what was broken about my brain, but this made sense to me. If it doesn't make sense to you, maybe study the formulas really quick and use those on your brain dump. Just put them down that, vital capacity is, IRV plus TV along with ERV. Right. The good news is if you get a question about total lung capacity or TLC, it's everything combined. Right. That's the good news. That's the one that you want to get the question on because that's literally everything. And then, do you have to know the milliliters and kilograms? No, you don't have to know that. You just have to know, what they are. And they may ask you saying that functional residual capacity is the combination of residual volume and expiratory reserve volume. So you do kind of have to know the formulas, but don't start freaking out here. Because again, lung volumes are not going to be 90 questions on your board. You may get 2 or 3 questions on it, and they're not all going to be the addition and subtraction problems. They're going to be that, well, tidal volume is what type of breathing, or residual volume is a problem in what condition. If I have something like pneumonia, where I've got fluid in my lungs, which one of these is going to be affected? It's going to be my inspiratory capacity or my expiratory capacity. What do you think?
Inspiratory.
Usually inspiratory, usually, but in general, that's a trick question because what's going to be affected is both. It's going to move the whole thing up, right? Now, inspiratory is going to be harder because you're fighting against the fluid, right? That's the problem. It's going to be more difficult. And are you likely to get that question? Probably not. But if you ever work in a ICU, you have to find out, because what you'll find is those patients work really extra hard to breathe in, but they're breathing very shallow because they only have a certain amount of the lung to breathe with, right? And the other problem with that is the diaphragm then sometimes is not able to breathe out as well. Lung butter. Lung butter. Right? Lung butter is the stuff that patients cough up, right? Again, good news is most of this is now being taken by respiratory therapy. So hopefully this will never be in the boards ever again, but we still have to know it, right? There might be 1 or 2 questions on it. Remember a couple of key terms. Fremitus. What was fremitus? Do you remember what fremitus is?
The sound of rattling in your lungs.
Yeah, fremitus is the vibration of the lungs. Yes, right? Do you remember how we test for fremitus? The 99 valve sound. There we go. Good. Yes, Brooke. Good. Right? That's where you're going to put your hands on different parts of the lungs and have them repeat 99 forcefully. And you're feeling for even vibrations. And you're feeling for, like Riley said, rattling that's going in there rather than a nice smooth vibration. That tells us something's going on. Percussion of the lungs is beating, right? And remember, when you're going to do percussive therapy, we start with vibration and then we move to percussion, right? We want to make sure the tune is there in their lungs before we tune them up, right? So you're going to vibrate a little bit and then start beating them. When they cough stuff up, we need to know how much they cough up, what color it is, what's the consistency, and what's the smell, right? I heard that they're now looking at having us taste all of their lung butter, but that's evidently not allowed. I'm just joking. I'm joking. I made Riley sick. That's good. Right? So remember, vibration first, percussive, and we usually going to do fremitus at the very beginning to help us figure out where we need to do those percussion and vibrations at. Postural drainage is going to work together with the active cycle of breathing, right? The diaphragmatic breathing, lateral expansion, forced expiration, right? I would rather call forced expiration coughing up lung butter because I think that makes it much better. And I love the term lung butter because it freaks everybody out. That means before they can do postural drainage, they also have to understand active cyclic breathing. When they're kind of hanging upside down, that is not the time to teach them active cyclic breathing. Time to teach them active cyclic breathing is when they're upright, so that when we go into the postural area, they're able to use ACB to clear it. Postural drainage can be done via gravity or along with percussion, but all of them work on a gravitational concept, meaning we're going to use gravity to drain specific areas of the lungs by the position we're putting them in. And for the most part, having a functional working idea of the anatomy of the lungs answers those questions. So if you remember where these lungs are located at, that helps you know what position you need to put the patient in to drain them, right? Upper lobes, I'm more than likely going to have them more upright. Lower lobes, I'm probably going to have them in Trendelenburg.
So I have
all of those.
I have a question about the drainage. So it's supposed to be like opposite of where the problem is. So
Yes.
we're trying to drain up. Is that correct?
Yes, trying to drain up into those bronchioles up here, right? So we're trying to get them up here so that we can out the lung butter. my mouse just messed up. There goes my lung butter, right? So yeah, we got to get it up here into the main bronchioles. So yes, it's opposite of kind of where they're located at. Exactly. And Brooke says she got a question that was on pulmonary tests conducted by oscillating over the patient while repeating 99. Yeah, that bronchiophony is probably not going to be a likely question, Brooke. I'm just going to tell you. Bronchiophony is Fremitus. And we usually use Fremitus more than we use bronchiophony. But when you're looking at that, if you broke the word down, you could probably answer that. Bronchio, listening to the lungs, right? Or phony, listening to the lungs, bronchiophony. But yeah, I can see how that would be frustrating. Fremitus is more likely to be the question.
Mr. McKeever,
Yes.
I had a question from one of last night's questions with the COPD patient and the drainage.
Mm-hmm.
So I was thinking, like, due to COPD, I didn't want to lay him down all the way. I don't know. I probably overthought the question, but do we like have to modify for COPD, or is it only for like congestive heart failure?
I honestly modify for COPD too.
Okay, so if it doesn't state that like your patient is unable to have it like performed in the supine position, and then that's when we would go down, right?
Yeah.
See, okay.
Yeah, and I again, I think that was one of the questions that was probably, I think that was when I was at my last wit's end last night, because
Yeah, I was so mad. I thought I got it, but
it needed a little bit more clarification. That's kind of what we talked about last night when I talked to Dr. Crane. Is it's not that his questions are bad, he's just missing some key. And his comment to me was, I know that I didn't add that, but I was trying to short a question to, you know, make it easier to read. I'm like, well, making it easier to read then makes the questions a little bit more vague.
yeah.
Right, because then is it this? Is, well, I didn't know that I couldn't do that, you know. So that's when we get in that little bit of an argument about it. Yeah, if on the boards, if it says that you know, it'll say patient is unable to lay down or has shortness of breath when laying down flat. That's when you know you can't put them in that position.
Okay.
Does that help?
Yeah, I just wanted to make sure if, like, something.
Yeah, it's gonna be a little bit clearer. And again, I understand his principle of shortening it so that he doesn't make you guys read 50,000 questions, but the boards are going to be long, so you kind of got to work your brain into that anyway. It's just the way it is. And you guys that have taken the PED have seen some of those questions can be long.
Mm-hmm.
Yeah.
Okay, thank you.
Yep, no problem. So yes, like Riley said, just thinking about whatever position those lobes are in, reverse them, and that's your drainage position, right? So if I'm working my right lower lobe, that's down here. In order to get that to drain, I have to get my head down and get my body kind of like this to get it to drain out, right? So don't memorize. I memorized where the lung parts were. And then exactly like I said, I didn't think of reversing it, but it basically is reversing the lobes, right? And the question is going to have, on these type questions, we'll have one specific right answer. It'll be very clear that that's the right answer. And then I'll have 3 that deal with other lobes. So like it'll say, if I'm doing right lower lobe, it'll say, so, yeah, seated, recline, seated, forward leaning, supine with legs over a bolster, or, you know, I don't know, Trendelenburg with right arm overhead or something like that, right? And that's when you go, oh, well, only one of those makes sense. So it's not totally going to be, you know, they're not going to be like, you know, laying prone over a pillow plus right arm, right or side, left side laying with arm overhead or something like that. They're going to be really specific on it. All right, last thing we're going to talk about, and I think you guys are pretty much burnt out of me for the past several weeks. Open packed versus closed packed, right? I had a couple questions, not questions on this, just kind of, can you please just go over it one last time for us? Open packed and closed packed. Remember, open packed is the position of maximum mobility. Closed packed is the position of maximum stability. Right? So open pack means it's able to be moved. Closed pack means typically not able to be moved. All of that ties into our capsular patterns, so that if the patient presents with a capsular pattern, it's going to tell us we may need to mobilize the joint. And to mobilize the joint, we need to be in open pack position. So for the hip, I divided this into just the general joints, right? So for the hip, my capsular pattern is medial rotation is the main problem. So internal rotation. And then also limited in flexion and abduction as well. But I'm going to be honest, in the clinic, if I've got a patient that just has medial rotation problems, I'm still probably going to mobilize, because more than likely they're actually capsular. But it's medial rotation with flexion or abduction or both. The closed pact of the hip is full extension, medial rotation. They're locked in. And that makes sense if capsular is that they can't get medial rotation. Open pact is about 30 degrees of flexion, 30 degrees of abduction, and slight lateral rotation. So kind of out here like that. That allows me to mobilize that hip best. And the way I always remember that is if I was to stand in their leg and have their leg kind of wrapped around me, that's my open pact position. The knee, usually greater limitation in flexion than extension, no limitations in the actual screw home mechanism, no limitations in the rotation. For the knee, closed pact is typically full extension, but honestly, full flexion also would be pretty close to closed pact. But full extension is definitely closed pact to the knee. That's why we focus on getting full extension. Open pact is about 25 degrees of deflection. You know, so just kind of resting over a bolster is what I remember for that. And that includes mobilizing for the kneecap as well. If you get a mobilization question on the kneecap, you have to have the knee in open pact. For the ankle, this is the only one that it gets a little bit confusing because you have two different joints. You have the talocrural and the subtalar joint. But the main idea I think of here is my memory for this is plantar flexion and inversion. Plantar flexion and inversion tells me it is a capsular pattern because those are the two main restrictions, plantar flexion and inversion. And the main thing I think about that of is, what do we have most of? We have most plantar flexion and inversion, right? We have less dorsiflexion, we have less eversion. So those are the two main things that lead me to a capsular pattern. Full closed pack is full dorsiflexion of the foot. And then open pack is just in that resting position where your foot's kind of dangling and it's a little bit in plantar flexion and not really in inversion or eversion. It's kind of dangling. That's your mobilization position. The shoulder, the one also thing to remember is that scapulohumeral rhythm, because I've seen a couple questions come up on that, right? The first 30 degrees is pure shoulder motion. After that, it's 2 to 1. So make sure you kind of remember that. Again, likelihood of you doing math on this is low, but just remember that it is a 2 to 1 scapular rotation. For the shoulder, external rotation, abduction, and then internal rotation would be the ones that key you into it being capsule, right? That's the best way to remember it. Yeah, external rotation, abduction, internal rotation. Remember those in three, that direction. Closed pack, right, is abduction and lateral rotation. Opened is 55 degrees of abduction, 30 degrees of horizontal adduction. So kind of here, right? We kind of have it out in this position here. That allows you to mobilize the shoulder. The wrist, capsular pattern is equal loss of flexion and extension, slight loss of radial ulnar deviation, but mainly equal both. And the position for mobilization is neutral. And then the closed pack is either extreme flexion, right? It's either extreme flexion with ulnar deviation or extreme extension with ulnar deviation. Either of those locks that wrist in. Ulnar deviation is the key because that's going to lock those carpal bones in that they can't move. And then when we get down to the actual hand portion, when I say the hand, we're talking about all the little joints of the hand. You're going to have equal loss in all motions. So equal loss in flexion, equal loss in extension, equal loss in abduction, adduction. Closed pack is full fist of the hand, right? That's close packed of the hand. Thing like this. So if I wanted to mobilize my PIP, I need slight amount of flexion in order to mobilize it. And then I can mobilize those joints. And that was all I had prepared for today. Are there questions? Is everyone surviving? On a scale of 0 to 10, where do you feel you are on confidence level? 10, okay. Okay, 7, I'll take it. Okay, Brooke, give me your number. 6, okay. What about you, Reagan? Where are you at? 7? And we'll wait till Anthony gets in on the second ID here. Anthony says 8. Okay, good. So here's the deal. If I was worried about you, I would say that you would say I'm a 4 or 5. That would be where I'm worried. If you're over 5, then you're exercising at the right capacity and you're really working your lungs, because you're working on that modified RPE at this point. Jason's really working at modified RPE at this point. He's running a marathon. Where I stand, and this is personal coming from me, if I was the overall, the whole class, I'm a little worried. I'm probably at a 5 for the whole class, just because the whole class in general. And the reason for that is I've only seen you guys on a regular basis. So Jason, or Anthony, I'm sorry, Anthony, you can bring your hydro flask, but you have to keep it in the locker outside the room. You can't take anything in with you. They have they don't have a calculator, but you can't take earphones. They have headphones for you, bro. You can't take a calculator. They don't necessarily have a calculator, but any math you're going to have to do, Anthony, can be solved with a sheet of paper. It's not going to be super complex math. But yeah, so anything that you take into the building with you has to go in the locker they provide you. So they give you a locker and they give you a key. That's kind of like going to the, when you go to like the water park and you get that locker with that little key that you wrap around your wrist or whatever. That's kind of what you get there. 2 forms of ID, yes, please. I brought like 4 just to be safe. I was just like, I've got my passport, I've got my ID, I've got a credit card with my photo on it, I've got my school ID. Yeah, I just brought a lot with me just to be safe. And one of the things I did the night before, if you live in a safe area, don't do this if you don't live in a safe area, is I locked all of that ID in my glove box, because that way I could remember and I didn't forget it. But if you live like where I live now, don't do that. That would be very bad. Somebody would see you doing that and steal it. We just had a student have their car broken into on campus because they took all their stuff out to their car, and the homeless people saw them putting it out in their car and walking away, and they broke into their car and took their computers and laptops, all their books. Ironically, one of the pawn shops called us because they had the Pima sticker on their book and the person's name. So they actually called us, which was kind of nice. And the person got their books back at least. I don't know about the computer. The pawn shop probably wanted them to pay for that. I'm just saying. They have limits of their generosity. But yeah, so 2 forms of ID. And it is, so whatever date it is, I would suggest if you haven't already, at some point this weekend, drive the drive. Just to be safe. Just take a quick trip down there, find out where the coffee shop is, find out where the bar is, and that way you're prepared for before and after. And then, all of you will see, it's funny because you'll see everyone at the coffee shop going in, you'll see everyone at the bar coming out. Right? Or just get prepared and be waiting for people, right? If you finish early, it does not mean you did poorly. So don't totally start freaking out if you're like, oh my God, I'm done and I've got 45 minutes left. I must have screwed up. That doesn't necessarily mean it. Just may mean you were quick that day. Just the same, if it takes you all 4 hours to complete it, it doesn't mean you're a bad person. Right? Some people take a little bit longer to process things than others. I finished with 2 hours left. And I literally walked out of that going, I screwed this whole thing. I was so convinced. I was like, I hope Walmart's still hiring greeters because I've got a career as a greeter at this point. And I ended up getting a high score. It's just that I evidently either got easy questions or just questions I was prepared for. And it was just like, boom. And I was going through it. I'm like, man, I'm going through these too quick. I got to slow down. And I slowed down. I'm like, oh, now I can't think. I got to speed back up. And I was just churning through them. make sure that you got some food in your stomach that day, right? Because you're gonna be sitting for 4 hours. Make sure that you've got, you know, good night's sleep. I know that's the hardest part of it, but you've got to get a good night's sleep the night before, right? That is not the night to be playing Eve online till 4 o'clock in the morning. Yep. I'm really rooting for you guys. You know, please pass. That's all I'm asking. But even if you don't pass, I'm not saying I'm out. I don't want to jinx any, but even if you don't pass, I still love you and I'll still be here for you starting the next week. So I'm not going anywhere. I have a vested interest in making sure you guys pass. And for those that are testing in October, I'm going to continue doing my weekly sessions with them until October. So, you know, there's a couple of your classmates that are rescheduling, and that's fine. They're allowed to. We'll just test in October, right? I really appreciate you guys have been showing up. I'm going to be honest, you know, almost all 5 of you guys have been my troopers that have been here through this whole thing, and I really appreciate it. You know, even silent there, Reagan. Reagan's been kind of quiet the whole time, but I know he's always been there. Same thing with Anthony. It's kind of rare for Anthony to be this quiet, but I think he's focused on passing the boards. So Reagan, what I understand is you guys should find out within a week. I had this discussion, like our finding out is pushed back for like a month. Your finding out should still stay within 10 days is what I'm just going to say 10 days because of the weekend. Right. So, and, you know, don't freak out about it. Don't worry about it at that point. There's nothing you can do. Once you're done, there's nothing that's going to change it at that point. Just wait till they tell you. You guys are lucky. They used to mail the results. That was worse. Like it would take, and think about it for a second. I lived in rural Pennsylvania. So that meant that my letters came via the carrier pigeon once a week. So yeah, it took a while till we got results. And literally I found out from the boards before I found out from my test results because my license posted. The boards are going to be on like the Nevada board is going to be on a retreat next week. So not the 5th, but the week after that. So when you get your results, your license probably won't post till that. So it's next Friday. Next Friday is the 8th. If you get your results, say you're testing next week and get your results on the 12th, your license probably won't post at least until the 22nd. Because they're on retreat till that Friday. And they're doing it. So and likely if you're getting your results by then is probably low anyway, just to be honest. Oh, you haven't? Okay, I'm going to send it out then. Forget it. I give up, Anthony. I'll send an email out about graduation. How's that? And for those of you that sent me the email about not having your graduation thingy, the certificate or whatever that thing's called, I talked to Miss Patty. What's that? Diploma? Thank you. Yes, that thingy. I talked to Miss Patty and we're getting them taken care of. So I just went and we have to order the new one because Libby has to sign it from main campus and then brings it up to me and I sign it. So, or not main campus, but down in Tucson. So we're taking care of it. It just give me a little bit of time, and with the ab test and everything going, everyone's freaking out. I had to go be nice to Miss Patty and bring her a cup of coffee. That worked well, I found out. I'm finding out that bribery works really well when I need to get things done. I know it's just, I know it works everywhere else. I didn't think it'd work in academia. I'm like, I need books. I bring Becca a cup of coffee. I need something done with Patty. I bring her a nice cup of coffee. Suddenly it gets done. It doesn't work for me though, just to let you guys know. I'm not going to help you pass your boards for me a cup of coffee. But hopefully after all this is done, then we can actually sit down and have a cup of coffee as peers, as you guys are PTAs. That's what I'm hoping for. Does that sound like a plan? All right, I'm going to stop recording as this kind of ends.